Assalamualaikum dan selamat sejahtera. My name is Dr. Akram. I'm a lecturer and ONG consultant in HUSM. So today I'm going to share with you my lecture on infertility, ultrasound in infertility. I'm just going to give you a brief explanation regarding ultrasound in infertility. These are the outline of my talk. Number one, I'm going to talk about the assessment of uterus and endometrium. And then I will discuss regarding assessment of ovary and ovulation. It is by ultrasound, okay? And then ovulation and tubal factor. And then I will be discuss regarding about infertility management, such as seminal fluid analysis, and then ART treatment in HUSM. Okay, all right. So first things is regarding the assessment of the uterus. Okay, so everyone will do a ultrasound on your patient when they come for infertility workout. Okay, so number one, you want to scan with a full bladder. Why? Because a full bladder will displace the bowel and identification of the uterus will be easy. So this is the bladder, and then this is the uterus at the posterior part here. Next, you are going to measure the uterus and the endometrial thickness. Okay, take the length of the uterus from the here fundus until the cervix here, and then the width of the uterus. Okay, the diameter of the width usually is around 7 times 5 centimeter, who are multipara, and then in nulliparous usually 5 times 3 centimeter. Okay, and then finally you're going to measure the endometrial thickness. Okay, after that, you are going to put your probe in transverse view so you can see the view of the uterus and the endometrium. Okay, so that you are not miss any pathology of the uterus, especially in bicornuate uterus. Okay. Okay. Another important thing is you know your basic about the menstrual cycle. Okay, as we all know, menstrual cycle can be divided into follicular phase and then secretory phase. Okay, and in the middle, using day 14 is ovulation. Okay, what you are going to stress here is the endometrium thickness in these two cycles, the follicular and luteal phase. This is because of the estrogen and progesterone effect. Okay, so during the follicular phase, the endometrium is not that thickened, but in the luteal phase, it will be thickened. Okay, because this is preparing for implantation. Okay, the endometrium. Okay, shortly just after patient having her menses, the endometrium will appear like thin white line like this. Okay, this is just after the menses. Okay, and then in the follicular phase, you can see started to see a trilaminar layer. Okay, one, two, three. Okay, and then when she reach in ovulation, okay, the trilaminar become more obvious with whitish outline like this. Okay, and then when the patient went to the secretory phase, the trilaminar layer disappear. Okay, and it appear thickened. Okay, it can go up to 14 millimeter of thickness. Okay. Okay, next you are going to focus on the ovary. Okay, ovary, as you know, is very small. The size is 3 times 2 centimeter. So by transabdominal scan, sometimes you can see the ovary, at the side here. So the measure around 3 times 2 centimeter, and you can see the antral follicles during day 1 till day 5 of menses. Okay, so the antral follicles uh, is about 3 to 11 follicles measured less than 10 millimeter. So these are the during by using the TAS. Okay, then you're going to do a TVS, transvaginal scan. So this is to get a better view of the ovary. Okay, not everyone can see by TAS the ovary. Okay, by TVS you should can identify the ovary. Okay, how you are going to look closely at the site of iliac vessel. These are the vessels. Usually the ovary will lie next to it. Okay, you use your color Doppler, and then next to it you can see the ovary. Okay, so you scan it by transverse and longitudinal, and then you can measure the follicles, and if you ever can see the dominant follicles. Later we were going to discuss about the dominant follicles. Okay, now about the dominant follicles. Okay, all right, the follicular growth. Okay, the dominant follicle has linear growth around 1.4 to 2.2 millimeter per day. Okay, so usually you're going to start to identify at day 9. Day 6 is too early. Alright, so you want to see your patient at day 9. So from day 9, then you can start to find the dominant follicle and then measure it and monitor it, because you know it will grow 1.4 to 2.2 millimeter per day, and by the time at the LH search, the size of it will be 18 to 20 millimeter. These are the dominant follicle. Okay, again, you're going to start at day 9 of menses. Try to find the follicle and then track it. Track it, and then you will estimate around the measurement of 18 to 20 millimeter. So when you get the measurement of 18 to 20 millimeter, this at the time of the LH search. Okay, so the follicles are dominant. Okay, after the ovulation, the corpus luteum is identified. So you can see it by using the color Doppler, and then you can see a free fluid. So this is indication of ovulation. Okay, so we are going to talk about ovulation. How to find the ovulation, how to determine the timing of ovulation is very crucial. Okay, if you look at the menstrual cycle again, for a patient who have regular 28 to 30 days cycle, her menses will be around at 14 days. Okay, around 14 days, right, at day 14. So what you are going to do is you're going to take the day 21 serum progesterone around here. Okay, so the serum progesterone, okay, the green one, alright, around here is the highest peak. It should be more than 30 nanomole per liter at this time. So this is indicated ovulation. Next is you also can use the OPK, ovulation prediction test. Okay, so patient will predict her ovulation and then check her urine to see the test whether it's positive or not. This is indicated in LH search. Okay, one of the tests is clear blue. Right, and then the best how to indicate is still by using the ultrasound. Okay, so by using ultrasound, as I mentioned just now, you do the follicular tracking. Start from as early as day 6, but usually you go for day 9. So it starts from day 9, and then you do a follicular tracking until you find a dominant follicle. Okay. Okay, the next step is you're going to test whether the patient have patent tubes or not. Okay, so by using HSG or hysterosalpingogram. Okay, it will be done by the radiological colleague. It's by using an X-ray and X-ray and then a contrast study. Okay, so we can see the cannula is insert, okay, and then the contrast will be insert, will be pushed into the uterus, whether you can, so you can see the outline of the uterus. Okay, it's a normal outline, this one. Then the contrast will go into the fallopian tubes, so you can see the outline of fallopian tubes, and it will be showing a spillage. So these are patents, both right and left tubes. Other investigation that you can do is HICO-C. Okay, HICO-C is another non-invasive investigation where it uses ultrasound to detect the patency of the tube. Okay, the same principle, they will inject the solution, and then by using ultrasound, and they will see the outline of the uterus and then the fallopian tubes. But bear in mind, HICO-C is very difficult because you need to have a good ultrasound machine and a good ultrasonographer to look properly the image, ultrasound. Okay, all right, and it's being used using transvaginal scan. Okay. Compared to HSG and HICO-C, I would say HSG is much better image to see the patency of tube compared to HICO-C. Okay, next you can do laparoscopic and dye test. This is quite invasive, so you reserve to a patient who have other diseases that you want to diagnose. For example, if patient have any endometriosis, or she has PCOS, that would need a laparoscopic ovarian drilling. Okay, so this is the laparoscopic view. You can see the uterus here. This is on the ovary. Yeah? So on right side of the ovary, this is the left side of the ovary and tubes, and then injection of the dye, methylene blue. You can see this test is okay, and then this side is also patent. Okay, right. So this is diagnostic. Some bullous of endometriosis, vesicle types of endometriosis in this patient. Okay. Okay. Next, you're going to check the husband, the seminal fluid analysis. Okay. So these are the WHO reference value for semen analysis. There are fourth and fifth edition. The latest one is the fifth edition. So you are going to check the sperm concentration. It should be 15 million per mil, and the total sperm count should be 39 million per ml. Okay. Next, you want to see a mortality more than 40%. Okay, and then you want to see the morphology. Okay, the morphology should be more than 4%. Okay. Okay, these are the management infertility in briefly that what we do in HUSM. Okay, first you have to counsel both couple, husband and wife, and do investigation, mainly the investigation in the wife and then also the husband. Okay, you want to take a day 2 follicle stimulating hormone and luteinizing hormone. Then you want to take day 21 progesterone. You want to take also prolactin, thyroid function test, testosterone if you suspect patient to have PCOS. And then you want to do semen fluid analysis for the husband. You want to do ultrasound, and then next you are going to do HSG, okay, to check for the tubes. Okay, once everything results, and then you have the diagnosis of infertility and the causes of the infertility. Majority of it is anovulation, right? So you're going to induce the patient for ovulation induction drugs. So you have two drugs, groups of drug. Number one is the SERM drugs, which is clomiphene citrates, and then a higher drugs such as recombinant FSH. Okay, we go for the first, the clomiphene citrate. You can start from 50 milligram up until 200 milligram, and then it will take during day 2 to day 6. Then you do the follicular tracking until you see the dominant follicles. Next, you can also use the recombinant FSH such as gonal F, Purigon, Humoc, Folliculin. And then at a similar method, you must do also the follicular tracking. Track the follicle until you see the dominant follicles. Okay, then you can proceed with two procedure according to the patient preference, or the where the patient can afford. Okay, you can go for IUI or you can go for IVF. IUI will cost around 400 ringgit, and then the IVF will cost around 8,000 ringgit. Okay, alright. IUI success rate is around 10 to 15%, and IVF success rate is 15 to 20%. This can be it can change over the years. Okay, and it differs between the fertility center. Okay, I'm going to share to you how we are going to do an oocyte retrieval in HUSM. Okay, so it's by using a ultrasound probe, and then these are the needle. Yeah, we're going to insert again. It will come out at the tip here. Okay, right. So you can see here, these are the dominant follicles. Okay, so I'm going to suck the one of the follicles here. So we will suck the fluids inside the follicles, where the oocyte are inside these follicles. Okay, alright. So I'm going to scrape at the follicles wall. Here is the follicle fluids. Okay, is drained into the canister. This canister is maintained at 37 degrees Celsius. Right. These are our embryologists who are going to analyze the follicles fluid and to look for any oocyte inside the each follicles. Okay. Right. So she's going to go very tediously to look for the oocytes, and only under a trained eye that you can detect. These are the one of the oocytes. Okay, and it's not clear in this video. So another one is, this is a bubble. Okay, so another one is around here. Okay, okay. Next is going to about embryo transfer. Okay, so these are the embryo around 3 days. So it has multiple into a lot of cells. Okay, around 8 cells Okay, so I'm going to insert to the patient to transfer the patient. Okay, so these are frozen embryo. Okay, so there's frozen embryo. Okay, these are the uterus. Okay, bladder. Right, so the cannula is inserted inside. Okay, you can see the cannula start to enter the uterine cavity. Okay, so up to the fundus here, and then start injecting the embryo inside. Okay, slowly. So you can see a hyperechoic area here at the area of the fundus. Okay, so these are procedure that IVF, the embryo transfer. Okay, so take home message from this lecture is infertility is not the end. So investigation of the couple is very crucial. It should be investigated properly. Okay, a lot of people just investigate the wife and forgot to check the husband. Okay, both couple. So you have to manage both couple accordingly. Okay, you should bear in mind 50% of causes of infertility is due to the female factor. Another 20 to 30% it can be from the husband. Okay, so you have and finally you want to pray so that children is a gift from Allah. All right, that's all. Thank you. Well, that's all about the briefly regarding ultrasound in infertility. I hope you can understand and can apply into your practice. That's all. Thank you for your attention.